All right. So first thing is I just want to welcome everyone to our official first what we call success session. We've had some other sessions where we've done other things, but we call these the success sessions because these are presentations where we highlight some of the exceptional work done by either Process Village students or partners of Process Village. And so this is our first official success session. I want to thank everybody for being here. And depending on how many people we have, we may get into some introductions of people who are on the call. We actually have some students who are current students of Process Village on the call, as well as we got some people who are just partners of Process Village who are here as well. So that's kind of what the success session is. My name is Jazz Patterson. I am the founder and president of Process Village. And in a minute, I'll get into exactly what Process Village is. But first, I want to talk a little bit about today's success session. And it's with Hamed Hijjazi. And what makes this session, I think, a little different is that he did his project 100% virtually, which I've been doing this kind of work for 22 years. I've never done a project 100% virtually. So that was really something that I think was worth noting, as well as the fact that the hospital was in the Middle East, so another language as well. And on top of that, he actually had fantastic results that have been sustained through the course of, when did you finish your class, Hamed?
December of last year was when we were done with that,
So over a year's worth of sustained improvement, and he's not there. So I think that's worth a little noting. And so with that, I'd like to first start with Hamed. If you would just introduce who you are, give us your name, your current organization, your role, and maybe a little bit of Six Sigma background about you.
All right. Well, my name is Hamed Hijjazi. I'm a recent graduate from the University of Texas at Arlington. I've completed a master's in healthcare administration, and my undergrad was in finance, and I also acquired an MBA from there. Currently, I'm an employee at Parkland Health and Hospital System. I work in patient access in the emergency department. It's my first career in healthcare, and I'm very particularly interested in the revenue cycle aspect of healthcare. And I thought that it would be a great way for me to kind of get a firsthand experience of how things work, and basically the entry point of the revenue cycle. Lean Six Sigma was not a foreign concept to me. You know, we studied it in our operation management classes back in my undergrad and during my MBA. And I was aware of the importance of, using a proper methodology to improve processes. So whenever I was given the opportunity to, attend a course to achieve a yellow belt certification, I jumped right on it. And almost a year later, here we are right here. So that's about all I got from you right now.
Great. Thank you. I appreciate it. And now I'd like to turn to, there are some people I asked to join this call as panelists, just to provide a little bit of perspective based on their experience with Lean Six Sigma. So I'd like to kind of go down the list of people for the panel. The STEAM panel is what I'd like to say. And if you would just introduce who you are, your organization, your role, and a little bit of your Six Sigma background. And I'm going to start with Gloria, if you don't mind telling us who you are.
Yeah, hi everyone. My name is Gloria Woodcomb. I am the director of the respiratory therapy department and the neurodiagnostics department over at Texas Health Harris Methodist Fort Worth in downtown Fort Worth. I've been there probably about 36 years. I actually went there as a student and never left. So I'm committed to the hospital. And I've always done things based off of improvement, what sucked and what needs to improve. And I've tried improvement processes in so many different ways. And when we were offered the ability to do Lean Six Sigma, I jumped at it. And Jazz will tell you that I probably had about 8 different projects all at the same time I was trying to do, and had to give them out to different people so we could get them all done. And been very successful. All of my projects I've done are still bearing fruit today. And I'm currently a green belt, and will push a yellow belt onto anyone.
Yes, she will. Thank you, Gloria. Adway, do you mind telling a little bit about yourself?
Sure thing. As in, no, I don't mind, but thanks for hosting this. So my name is Adway. I'm currently a student over at the University of Texas at Dallas. I'm currently a junior majoring in healthcare management, and I've just been kind of trying to work with Process Village and Jazz to connect a lot of the great things that y'all are doing over here to students who today are really interested in healthcare management, and specifically things like Lean Six and whatnot. So definitely excited for the event, and I'm excited for people to watch this afterwards as well.
Thank you. Jared.
Hey, good evening, everybody. My name is Jared Lang. I'm the Director of Business Sustainability at Parkland Hospital. We've been here for about 2 years. My department has basically 2 departments. One's mostly data analytics, developers, architects, and then the other one's administrators that oversee high-level financial projects and implementation of it. My Lean Six Sigma background includes Lean Six Sigma Black Belt. Before Parkland, I worked for an architecture firm, helping with pre-design. One project we worked on was ED workflows in Nanjing, China. And so it helped basically improve the design of both renovations of hospitals and also net new hospitals as well.
Thank you, sir. I appreciate it. KP.
Hey, Jess, thanks. Again, my name's KP. I'm currently the CEO for our select specialty hospital here in Cincinnati and Northern Kentucky, oversight of 2 of our local hospitals and part of the Select Medical Corporation. I got exposed to Lean Six Sigma actually early on at Texas Health when it was becoming a new program and new initiative that Jazz was leading. And actually, I had the honor to work with Mark and Jazz at the same time, and got my yellow belt with them. And my project was actually the SERVE program, which I co-founded with Sonia. So that was pretty exciting. And unfortunately, have not been able to pursue any further with a green belt or black belt, but that still remains to be my goal eventually, to continue pursuing that operational piece of it. And for me, it's just what got me into operations and what got me into where I am in my career currently.
Thank you. Appreciate it, KP. So we have some additional people on the call. I just want to recognize them. I'm gonna kind of go down the list here, and if you'll just introduce yourself and who you work for, and let us know if you're working on if you're in the class. I think most of the people on here are in some class or another, but just tell us who we have. I'm gonna start with you, Anthony. If you don't mind just telling us who you are.
Of course. Thanks, Jazz. Thanks for everybody being on the call, and I'm looking forward to the rest of the presentation. But my name is Anthony Sansone. I'm currently serving as an administrative fellow for Allegheny Health Network based out of Pittsburgh, Pennsylvania. And I'm working with Jazz. I'm currently pretty much almost halfway through, a little less than halfway through our yellow belt training, and happy to be here.
Okay, thank you, sir. Mark, hey, do you have Judy Travis's phone number?
I think I do.
Do you mind? I know this is like an impromptu request. She's just having problems getting on.
Okay.
But before you do that,
Okay.
will you introduce yourself, sir?
Sure. Mark Davis. I actually with UT Southwestern. I'm part of their Lean Transformation Department. My title is Management Engineer 2. Been there for just over a year now. Been actually a black belt, Lean Six Sigma black belt for the past 11 years, doing process improvement probably for about almost, I guess, most of my career prior to this. At one time, of course, I used to work with Jazz, actually with Textile Resources and so forth. And that's actually really gotten my door into the patient care side of healthcare. Thank you for inviting me, Jazz.
Oh, absolutely. Okay, Kayla.
Hey, this is Kayla. I am currently with Allegheny Health Network. I'm the Imaging Regional Administrator. I've been with AHN for 18 years, and I'm currently in the yellow belt class with Anthony.
Thank you, Kayla. I see LaToya on the line. Do you mind jumping in and telling who you are?
Hello.
Hey, LaToya.
Hi. Yeah, sorry. Can you hear me okay?
Yes.
Good evening, everyone. LaToya Rivers is Zonga. I currently work for Honor Health, Outcomes Improvement Leader. I've had the pleasure of working with Jazz and Mark Davis and actually KP a long time ago. I've been in healthcare for about 15 years, but I really enjoy helping and supporting the delivery of care. Glad to be here.
Glad to have you. Michael?
Hi, everyone. My name is Mike Lust. I am the manager of radiology operations at Allegheny Health Network based in Pittsburgh, Pennsylvania. And I am currently in my yellow belt.
Thanks, Mike. Vikas?
Hello, my name is Vikas. I am currently an administrative intern at Texas Health Dallas, and I'm currently working on my yellow belt with Jazz as well in the hospital. And yep, thank you for having me.
You're welcome. You're welcome. Okay, so we'll go ahead and jump into it. And before we do, I do want to just tell everybody a little bit about Process Village. So I'm going to share my screen and give you a little bit of information about, what exactly Process Village is. So let me do that really quick. Let me know if you can see my screen.
Yep.
And we'll run through this. So again, this is the first success session. Project name, Operation Code Cleanup. But a little bit about what Process Village is. The mission of Process Village is to support the success of students, employees, and business owners by building strong community-based relationships through the application of Lean Six Sigma principles and training. I mean, to me, this whole ordeal is about building relationships in the community to help other people either gain experience or gain the tools they need to improve processes, or help businesses do what they need to do to improve their processes. That's our goal, and we strive to partner as much as possible with organizations so that we have this network of organizations that we can identify projects, and then if there are people who need help with projects, we can partner the two together and give them the experience they need to be able to do this kind of work. That's what we're about. What we do Six Sigma training and certifications. We also do consulting, as well as coaching and facilitation. But we're not just healthcare. So we'll do any of these services in healthcare, education, manufacturing, government, home construction. You may say, home construction, what's that about? Well, I'm very interested in home construction, especially with everything going on with COVID and the supply chain being affected and impacted. I think it is a perfect industry to get involved in, trying to make things more efficient. Their costs are going sky high. Their lead times are growing tremendously, and it's impacting the customer. So home construction, we would love to do it, as well as small businesses, and just helping small businesses become more efficient. Our specialties: cost improvement, flow efficiency, productivity and utilization, employee and customer satisfaction, workload balance and standardization, quality improvement, as well as office and supply organization. We have a yellow belt class that's coming up in January. January 10th is the start. $795 is the cost. And if you want more information, you can either go to our website or call us or email me. So that was my spill. And with that, I will actually turn it over to Hamed to start his presentation. I'm gonna stop sharing so you can take it away.
Thank you, sir. All right, can everybody see my screen? Is it good?
We can.
All right. So, the name of my project is Operation Code Cleanup. It took place at An-Najah National University Hospital. It is a private educational hospital. It's a 128-bed facility that opened up in 2013, so still a fairly new hospital. And basically, the problem that they had at this hospital was that they had a low code utilization rate, as in billing codes. So I'm going to kind of walk it through. This presentation kind of walks you through the DMAIC completed. So, all right, so with the first part in the define phase is to create a project charter. Essentially, I listed out the members of the project, the sponsor, Kamal Hijjazi, the CEO, our champion, who was Mahmoud Masad, the head of patient accounts, me as the yellow belt, and our initial team included Islam, the accountant, and Ferris, the physician auditor. Now the problem statement. So this, when I initially started, Jazz kept coming back and forth with me, telling me that I wasn't being specific enough. So at first, our problem was that we just have too many codes. Well, okay, we needed a number for the codes. And then I came back with the number, okay, we need something that we can measure over time. So at the end point, we came up with, for the past 7 years, the hospital has maintained one master file with the ability to add billing codes and without deleting any of the codes in the system. So they have 7,776 active codes as of September 2019. An average of resulting in a 26.85 monthly average utilization rate over a 12-month. This caused confusion billing, maintaining accounts, and resulted in lost revenues. So in order to get to that utilization rate, what we had to do is go over Excel spreadsheets over the last 12 months at the time. And I essentially just used pivot tables to kind of identify how many unique codes were used every month to kind of get an average utilization rate over a 12-month period. So took a little bit of calculation, but that was where we were at that point. So the goal of the project was to achieve a utilization rate of at least 80%. Some of the benefits of this include more compliance, less billing errors. It eliminated costs with unnecessary billing and increased employee and patient satisfaction as well. The areas that would have been impacted were the billing department, the item master database, and patient registration. And the scope, it was set to be completed and implemented by December of 2020, which was about 3 months out from the start of the project. And it focused on the billing master program and the usage of the system. And of course, I had the clerical staff that was able to assist, along with the software that we used was primarily Excel and SPSS for analysis purposes. So with that being said, the first step that we took was the voice of the customer, where essentially we want to hear the problems from the people most directly involved with the process. Over here, as you can see, I've listed the members of the first meeting that we had. And this was a meeting that lasted for about 2.5 hours. We kind of all got together and we wanted to focus on just the problems involving the high utilization rate. As you can see here, there were duplicate codes in Arabic and English. I might need to mention that at this hospital, they don't have a formal coding format, sort of like we have CPT or ICD-10 over here. It's just kind of, put whatever you want in the system and it'll fly. So we had duplicate codes in Arabic and English. There's confusion between kit and procedure codes, where the kit should be included in the procedure. There were duplicated items based on brands. Items from billing and inventory master lists were getting mixed up. There were new codes that were entered by newly hired doctors who maybe weren't familiar with the methods at the hospital. The naming convention was inconsistent. Some codes just simply had the name of the medication or the kit typed out, where others were using a variety of abbreviations and numbers. Some of the codes were being overly specific. There were 2 codes made for items that have student discounts. Since this was an educational hospital, they're associated with the university. So students at the university would actually get discounts if they were to be treated at that hospital. The system that they were using doesn't notify any users when a code is already in the system. There was no clear standard on what items should and shouldn't be billed. There were some items with very minimal price that really didn't need a bill or needed to be added to the billable item list. And there was no cleanup for codes on discontinued items or just no code maintenance in general. So this was, from what I was told, this was a pretty good feedback from the voice of the customer, because we got a lot of the root problems addressed in this one meeting. So after all those problems were brought about, went ahead and created an affinity diagram to kind of categorize the problems, which we came up with 3 different categories. One involving people, which would be errors made by employees themselves. The second would be any process issues, which is just flaws in the way the whole adding a billing code into the system is carried out. And then system issues, which is more of a software type of issue, just issues and obstacles created by the charge description master list. All right. Once all of those were defined, we identified the essential drivers that we needed to address in order to begin with the process improvement phase. And over here, it was important for us to get some critical to quality measures with a measurable goal, with an actual number on them. So that's what we've got highlighted here in red. So the first driver was to improve employee decision-making regarding code management. So we wanted to make sure that all of the codes moving forward are going to be in English, sure that none of the codes are duplicated. Our second driver was going to be improving coding procedures and system maintenance. So our critical to quality measure there was to make sure that all of the codes follow the same format and that all of the unused codes are removed from the system. And then our third driver was to improve the functionality of the item master list. And that critical to quality measure is to ensure that all of the items in the inventory list that are not billable and are on both the inventory and billing item master lists are removed from the billing item master. All right. And then we get to the Cypoc diagram. So Cypoc stands for suppliers, inputs, processes, outputs, and customers. At the very start, to put this together, it was easy to list out the process first. So as you can see here, the process kind of briefly is that the service or item identified is to be given to the patient. The item master list is searched for an existing code. Once the code is found, we add it to the patient's bill. If the code does not exist, the employees at the time would have to contact the finance department to add a new code into the system, audit the bill to check for any mistakes, and then to generate the bill or the invoice. Some of the suppliers to this. So basically the suppliers of codes, words, physicians, then we have the various departments in the hospital, such as the operating room, nursing department, finance, radiology, pharmacy, and laboratory. The actual inputs for these include things like the patient's condition, implants, surgeries and medical procedures, medical supplies, code creation, maintenance, radiology procedures, completed test results, and medication for patients in hospital for take home. All right. And then the outputs to this process include the billable procedure item, but we would also get duplicate codes, irrelevant codes, or the completely incorrect code for the service provided. So not all the outputs were actually beneficial to our procedure. And then our customers would have, were essentially the billing staff and the patients, the two parties that were most directly affected by the low utilization rate of codes. And then what I have here is a current state process map. So on the Cypoc earlier, we saw that there we had the process listed out. This is kind of a more in-depth map for the process. So at first, a service item is given or will be given to a patient. The billing or clinical staff pulls up the charge description master on the system. And then we have to see, is the item already in the system? If it's not, clinical staff would have to contact the finance department to add a code, which wasn't always the case, but this is technically what they should have been doing. The finance staff would add the code, and then you can select it from the system. So sometimes there's some time lost here while reaching out to the finance department. Next, the billing and clinical staff would add the code to the bill. The finance department reviews the bill, which includes a chance that the code may be incorrect. So if the code is incorrect, the finance contacts the billing clinical department to correct the code, and we kind of start back over here. If the code is correct, it will generate the bill and the invoice. And once again, there is some more time lost here, reaching out to the billing and clinical department from finance's end. So this phase of the measure, this portion of the measure phase includes data collection. So it might be kind of common sense to assume that, the more unused codes are, the lower the utilization rate is, but it is important to also visualize this data. So this is essentially what this graph is doing. Over here on the left-hand side, we've got the list of unused codes over a 12-month period. And the red line shows us the utilization rate over that period as well. So as you can see here, the month with the highest unused codes also corresponded with the lowest utilization rate at around 22.5%. So it's a good visualization tool here to kind of just show the impact of the codes on the utilization rate. And then once we got to the analyze phase, made up a fishbone diagram. It's a little similar to the affinity diagram that we had earlier. There were just a few more root causes that we added on to here. And we've organized them into human, which was the human error portion. The newly hired physicians, for example, or employees adding the codes or duplicate codes being added in Arabic. The methods here highlights just the whole process issue with it, such as having the inconsistent naming convention and not having a clear standard on what is or isn't billed. The codes themselves here are regarding the actual format of the codes. And then the software issues are going back to the system software. Here we added not having a barcode system resulted in more human error. So, as we were working on this project, more other issues were being unfolded, but at the same time, we wanted to focus on just the utilization rate for now. So once we had measured and analyzed everything in regard to the project, we wanted to begin with the improvement phase. So the initial problem statement was that the utilization rate was at a monthly average of 26.85% over a 12-month period. We had two key performance indicator values. Over a 12-month period, more than half of the codes were not being used, and some were not used for more than a year. Some root causes for this include that some codes are specifically for student discount. Some procedures were no longer or never even provided in the first place at the hospital. And there was also confusion between codes for kits and procedures. Some solutions, the solutions for the specific student discount codes were to use a visual control to indicate when an item was purchased by a student to give them a discount when generating the bill, rather than having a completely different code for student discounts. For the ones that were no longer provided at the hospital, we wanted to use a visual control to automatically highlight codes that have not been used in the past 6 months, making them subject to evaluation. And regarding the confusion between codes for kits and procedures, we wanted to make sure that moving forward, kits be included in procedures and to eliminate codes for kits. And then the other key performance indicator value was that the total number of codes in the system was 7,776. So the root cause of that were that inventory system codes from the inventory system were being added into the billing system. Items with an insignificant cost were being added to billing codes. And then the charge description master system doesn't notify users when a code already exists in the system. So to address codes from the inventory system getting mixed up, we wanted to use a visual control in the system to alert whether an item originated from the inventory department or the billing department. Items with insignificant costs, we wanted to set a clear standard on what price is considered too low to be billable. And then charge description master system not notifying the user when a code already exists. We wanted to create a kind of Kanban, which is kind of a visual tool to notify the user when a new code is needed, and to implement a pull system to regulate new codes added. All right, and I'll go over those two here in a second. And then this portion of the improve phase is the Racy Matrix, which is basically listing out which staff is going to be responsible, which staff are going to be accountable, which staff need to be consulted with before a decision is made, and which staff need to be informed once the decision is made. So when we're deleting unused items, the billing analysts are responsible for that. Finance department are accountable for that. And the IT analyst should be consulted with before deleting the unused item. Deleting duplicate items, same thing, except we're going to consult with the clinical departments instead of the IT analyst. When it comes to modifying item descriptions, we want to consult with the IT analyst, and we want to let the clinical departments know when an item has been changed. Developing a charge description master policy, that is up to the patient financial services manager. We want to, the CFO is accountable for any changes made there. We want to inform clinical departments about that, and we want to consult with an internal audit before developing any policy changes to the charge description master. And then to determine the chargeable level, in other words, what would be too low to be billed, it's going to be the same departments, except we're going to consult with the CEO before making sure. To secure board approval, the CEO was responsible and accountable for that. The charge description master maintenance, it's the responsibility of the billing analyst. Clinical departments must be informed. Patient financial services manager is accountable, and the CFO is to be consulted with. And then updating billing algorithms in the patient financial services system. The IT analyst was responsible for that. Patient financial services manager is accountable for that. We want to consult with the CFO before this is done, and to inform the CEO once it's been completed. And then this is a future state process map where we slightly modified the process map from earlier. So what happens here is that if the service item is not in the charge description master an on-screen alert notifies the user now that a code needs to be added. So this eliminates the time needed to reach out to the finance department and consult with them to add a new code into the system. The on-screen alert here also notifies the user whether the code belongs to billing or inventory, which reduces the chance that the codes may be incorrect. And then once again here, it saves us some time. The on-screen alert notifies the user whether or not to apply a student discount. Here, it saves some time reaching out to the, it saves some time on finances end to reach out to the billing or clinical department to adjust any codes. And it also eliminates the need to have a separate student discount code where it just applies a student discount to the total bill and then generates the bill or the invoice. So the two tangible solutions we have made for this system was a pull system and visual controls. So a pull system, which is typically used in manufacturing, which is where we basically don't produce anything until it's needed rather than overproducing. I kind of saw that overproducing codes was kind of an issue in this situation. So creating a system where we only add codes whenever it's absolutely needed to, where it doesn't exist in the system, would be a tangible solution. So the pull system was implemented there. And then along with the in-system alerts that would notify users of duplicate codes or if a code needed to be added, that was a form of visual controls that we used to address problems in this project. So once all of that is done, we finally reach the control phase. This graph kind of shows you the utilization rate from September 2019 till September 2020, which was when we started on the project. The changes were implemented beginning to mid-November right here, and as you can see, our code utilization rate went up by about 10%. So, and that's the highest it had been over the past 15 months over here. And then I kind of added this after monitoring the situation for a while. So this is kind of where the changes were implemented, but over the months, more and more codes were being cleaned up and training was being performed to make sure that everyone followed procedures on, when to add a new code, when to not add a new code, and keeping a consistent format. So as you can see here, up until June 2021, our code utilization rate had reached a point of 85.18%. And I believe we had something like 1,400 codes in the system. So it was a massive amount of codes that did not need to be in the system. And then finally, the action plan matrix, which is just sort of a plan moving forward to make sure everything stays consistent. Continuing the cleanup of the remaining codes. The due date was June 30th. For the most part, all of the codes have been cleaned up. There may be one or two codes here and there that they'll remove out of the system. So that's the only portion here that's been completed. The training of new staff and billing departments on proper procedures to add codes is set to, I'm sorry, this should be 2022, not 2021. As we hire more staff, we want to make sure that everyone is on the same page regarding policies when it comes to adding new billing codes. Monitoring the use of codes over the coming year, as well as the code master list. That's something that we're going to be monitoring, or the billing department will be monitoring up until the end of this year. Continuing to compile data visualization on monthly utilization rates to identify performance trends. That's my responsibility, and we've got it down up till June. But recently, really at the hospital, they've been going through a complete restructuring of the finance and the IT department. So I'm just waiting on additional information once they get that out of the way to continue to visualize the progress on this process. Monitoring the charge description master software, that's up to the IT department and is still in process until the end of the year. And then issue here that arises that the hospital realizes they may need a different vendor for the software, since the one that they currently have is not as user-friendly, and they would have to contact the vendor anytime they wanted to implement a change, rather than having someone who can just tweak it in-house. Monitoring reported incidences related to the charge description master, that's quality management's responsibility till the end of the year. And they're to analyze any feedback from employees about any issues with the functionality of the system. And then finally, we want to monitor compliance with the charge description master policies. It's up to the finance department to make sure that all methods used are following the updated policies. That was the end of my presentation. A few takeaways is that we realized that the finance department needs some serious restructuring. The IT department also needed to be reworked a little bit. But overall, the process has become a lot more streamlined. We also, sorry, let me just stop sharing the screen for now. Did the screen stop sharing already? Or
It just did. Yes.
okay. But there are a lot less billing errors now. Patients are more satisfied. We don't have complaints, as many complaints from patients. There's still always going to be complaints, but they've gone down significantly. We're working on implementing a proper financial reporting system as well at the hospital that I will be assisting them with as well. Hopefully I can have some, added financial improvements that I can actually visualize for everyone, should we decide to get any more updates on this project. But overall, I think it was a really great experience to be able to kind of help them with their very first Lean Six Sigma project. This was the first time they had implemented any kind of project like that at the hospital for process improvement using formal methodologies. But yeah, I'm open to any feedback or any comments on what was done, any suggestions, anything of that sort.
First of all, I want to thank you for the presentation. Thank you for taking time to rehash the presentation that you've already certified. So, he was like in our first class that we've had. So that's, we're on the fourth wave of the classes. So that's a while back, and he did an impressive job to remember all that stuff, and he's keeping track of it. So I do want to open up the floor for the panel, for Gloria, Adway, Jared, KP. Anybody just have any thoughts about the project, questions about the project, or anything they'd like to present? Yes.
Yeah, hi.
Hey guys, go ahead, Gloria.
Yeah, I just wanted to say great job. I'm very impressed, not only the distance, but the effort and the work. And I did have a question. Have you been able to determine if there's been any improvement in revenue to the hospital based off of improved coding?
In revenue, so basically this is not any, because as I mentioned earlier, they don't have a actual financial reporting system set in place at the time, but there has been improved revenue in regards to not having to go back and reimburse patients. It's just having less errors in the system also has helped make sure that there aren't any unnecessary costs going on as well. So it has definitely impacted the revenue. That the financial reporting is another portion of the project that I'm currently trying to get with the hospital management to kind of help them, create actual statements to kind of reflect the changes from last year to this year. So there definitely have been improvements to revenue, just not on paper yet. But I think they're pretty happy with what's going on right now. They're just reconsidering the staff that they have at the hospital as well, especially in the financial services department. They may be, from what they're telling me, is that they may be overstaffed as well. So I'm not too sure what's going to happen in that aspect. But in regards to revenue, it definitely has had a difference.
And then how did you get hooked up with this hospital for this need that they had?
Okay, so basically my father is the CEO at this hospital.
Okay, well, you know, that's not a bad thing.
Yeah. I kind of, whenever I signed up with Jazz, at first I didn't know much about the process village and what how the process was going to go. I thought it was just going to be, just an online class where, you just get your certifications done. And then, Jazz was saying, no, I need an actual project for you to work on. So I kind of just, was contacting people I knew here. It was just a little difficult over here because, it was at the beginning of COVID and everyone was kind of like, hesitant to bring me on board and to volunteer on a project. So, I just reached out to my father and he said, you know what, I have just the project for you. We can work on this together. And it worked out like that. So,
well,
yeah.
Good job.
Thank you. Thank you so much.
Yeah, and his dad used to work at Texas Health. Like he was just at Texas Health before that.
Yeah, he actually interviewed with Jazz once.
Yeah,
apparently.
He did. Yeah. I didn't know at first. I didn't realize it. And, I was like, okay, oh, man, I need to talk to the sponsor. And we get on the phone. He's like, Jazz, you remember me? You were interviewing. I was like, yeah, you're right. So it's a small world. He was
small world.
He actually worked for THR.
Mm-hmm.
Wow.
Yeah.
Any other questions? I think Jared, you had a question or a comment.
I just had a few comments. First off, really good job. I think you showed all the tools of Lean and Six Sigma. And most importantly, I think you did a really good job of telling the story of the project. Sometimes when people do good work, it's just as difficult as kind of telling the story from beginning to end. So I think you did a really good job with your presentation. The few comments I had was at the beginning, I think you did a really good job getting the voice of the customer. A lot of the time for executive projects, sometimes people don't go to the customers, which is where we're going to get the bulk of truly what's wrong and get the details of it. So good job with that. The second thing is at the end, you showed the structure that's in place for long-term success. I think that's probably the most important thing is because it's always easy to go in and make improvements, but if they're not long-standing, it doesn't matter. So I think by putting that structure in place, ultimately long-term success is going to be very, very good. And then the last comment I had, I think Gloria was kind of alluding to this, is, the main metric you looked at was utilization rate, but tell us, so what, right? Like you kind of answer the question to Gloria. And even if you don't have the numbers, it doesn't matter. You can name off some of the KPIs that you're listing, but tell us, what's the downstream effects of everything that you're doing? Because at this point, even though if you don't have baseline data and you might have future data, at least you can tell that story as well. I mean, from my understanding, I may have missed it, but it was the utilization rate and the number of unused codes. But ultimately, like, what does that mean? Like, if it's high, what does it matter? But you answered it, right? To Gloria's question, you said patient satisfaction, reimbursement, employee satisfaction. So not everything is going to be quantitative in measurements. You can just describe it and be prescriptive on the improvements. But I think that's like your home run at the end is saying, I did all this work, all these tools, etc. The main takeaway is this, unused has gone down, but all these other things were improved, and that was the downstream effect. So no real questions, just my 3 comments. Overall, really good job. I'm glad to see somebody from Parkland doing this. And I should connect with you offline and talk to you more.
Thank you so much, Jared. I really appreciate that.
Okay. You're welcome. Good job.
Jared, you're welcome. See, I got you. Hey, you're welcome. Okay.
Mutually beneficial, man.
Adway, I think you had a comment.
Hey, Ahmed, first of all, I think great presentation, very informative for someone I know who is kind of at my stage still figuring a lot of this stuff out. My question is a bit geared to maybe any students who may be watching this in the future, and I guess it's maybe more simplistic take, but I'm not sure what your background was like with Lean Six before this project, But what was your experience like actually utilizing, this DMake framework and then these various tools that you mentioned throughout the project, and how might you maybe recommend that somebody kind of start with understanding and utilizing these frameworks? Because I know with process improvement, a lot of times with students, at least, we kind of see it as a bit more general, like, here's an issue, here's how we fix it. But what are your takes on maybe how you actually use these tools and these frameworks to make things more efficient,
Absolutely. So before, using Lean Six Sigma, anytime we had a problem at my place of employment, I used to work in the finance industry. Everyone would always just rush to, here's the solution, this is what we need to do. Using these methodologies, I got used to asking, the 5 whys, basically. Why is this, just keep asking why to find the root cause of the problems. I think that completing this project has really changed my take on how to address problems, not only at work, just in, everyday life. You kind of want to just get to the root cause of the problem rather than focusing on solutions. And it was kind of difficult at first because in that first voice of the customer meeting that we had to keep redirecting staff to go just to problems, because in the meeting itself, everyone was trying to jump to solutions right away. And it's taught me that, you need a lot of patience to improve overall processes as well. You can't just try to jump the gun and, jump straight to the solutions. So I think it was a great experience. It really makes you think more in depth about problems, and I think it's a much more effective way to address any problems that you have using these methodologies. So I would recommend, any students to really take, a Lean Six Sigma certification, with Process Village too, since you get the the whole project experience as well. I think that's it's one thing to study it and learn about it in books, but actually implementing it to a real life project, it's a meaningful experience that you get to take with you as well. So yeah, that's I hope that answers the question well enough there. All right.
KP, did you have anything?
No, I think everybody really, kind of shared their comments. I think I chatted that. I think it's obviously a great presentation, and the fact that you did it remotely and virtually, I think it's very impressive. I know when I was going through my Lean Six Sigma project at THD, let alone being physically present to do what we did was difficult enough. But not only did you, obviously overcoming the language barriers that there may have been across seas, but I'm sure the time zone difference was obviously a huge factor too. So I think just a lot of different barriers and challenges that you were able to overcome. And I think that, in my opinion, I think that shows the true value of the Lean Six Sigma process. And when there's a will, there's a way. And I think you obviously proven that, and obviously successfully shown that. And I'm looking forward to see that kind of the second part of this project, maybe with the Greenbelt project, escalating on that, the financial aspect of it. And I think there's a lot of potential there for that too. So great work.
Thank you so much, KP. I really appreciate the feedback. And we'll keep you updated on any process improvements.
Yeah, if they need a CEO in the future, let me know.
Oh, okay. Absolutely, sir. Will do.
I know Mark had a comment and then Latoya. So let's go Mark and then Latoya.
Yes, sir. Thanks, Jazz. No, wonderful presentation. Yeah, very, very professional. But I guess, when you're working your master's with education, it's very well done. But I was wondering in regards to, it was along the lines, Jared was talking about quick voice of the customer, but I was wondering from buy-in from the customer, from the frontline staff on some of those recommendations and some of those changes, as well as was there anything discovered during this that you previously wasn't known of, like what's causing some of the issues?
So one of the main things that popped up kind of mid-project was the issue with the vendor, the IT vendor for the software. They discovered that the software was not user-friendly at all, which was a reason why a lot of the codes were not being deleted. If you wanted to make any changes to the system, you would have to put in a work order through the vendor, and then their employees offsite would have to go in there and implement changes. So that's one thing that became apparent, was the software itself. So that's something that they've also worked to change as well. And then just the structure of the patient financial services department was just very inefficient. Currently, they're working to restructure how the employees work, perhaps, train them in different areas, because they don't really want to lay anyone off. They kind of want to just rework how the whole finance department works in the hospital. So that's also another issue that they're currently working on, which is why I haven't had any feedback in the past 2 or 3 months regarding any updates on the codes, is because they're working on restructuring the way everything works in that department as well. So just for the scope of the project, we were looking at just the utilization rate, but there were definitely other issues that arose, but would need, separate projects to kind of address. It's not something that we were able to just address while we're trying to get the utilization rate up. Now that it's up, they're focusing on just the structure of the department overall. Yeah, absolutely, Mark. Thank you for the question.
Latoya?
Yes, sir. Great presentation. I just would like to add that what I thought was notable about your experience is keying on operational definitions. Be surprised how people throw around a lot of nomenclature in healthcare and really struggle that they're not talking apples to apples. There's so many complex concepts and discussions, and I thought it was very keen that you really focused on making sure that everybody understood the semantics and level set in that way. But I'm interested because, coding changes every year, if not biannually. Where in the sustainability of this, the re-education updates get discussed. I know the software and someone has to manage that piece, but in regards to just, changeover and staff staying up to date with information and being informed as things evolve.
Okay. Wait, was that a question? I'm sorry.
Yeah. Yes. Did you come up with any sustainability plans to ensure that everyone can maintain that level of understanding and be on the same page as things change?
Yes. So basically, the finance department came up with a formal training session, which they required, all current employees to go through moving forward, regarding things like, things regarding the chargeable billing level, the format of codes, just things of that nature. And moving forward, there's, mandatory training in place now for any new finance or billing department employees coming on board. So initially there wasn't any type of formal training, which was also one of the issues that caused the low utilization rate. So they definitely do have a new training program in process. So moving forward, hopefully, we don't get that same recurring issue. I'm hoping, but at least they do have a formal measure in place at this time.
Awesome. Good luck.
All right. Thank you, Latoya.
Adway, I think you said you have to jump off in a minute. Thank you for joining. We appreciate it.
Yeah, thank you, Adway.
Absolutely, yeah. Thank you guys for having me.
I think we have a question from Anthony, and then after Anthony, if there's any other of the current yellow belts that have a question for Hamed, please jump in.
Yeah, thanks again, Hamed, for presenting. I thought your project was very interesting, and I think one of the pieces of what you did for your project really stood out to me, because I'm in a very similar boat. And so you mentioned, because of obviously the location and COVID, that you did your project entirely remote. And that is actually what I've been doing this entire time as well, is doing my project remotely. And so Any tips or advice or any specific thing that you did that you found to be very, very helpful in this remote setting that, someone who's, in the middle of my course and in the middle of my project should think about and try to implement?
Okay. The most important thing for me was consistent communication with the team. It was a little difficult for me just due to the time difference. They would have to set their meetings towards the end of the day at maybe 3 p.m. and I would have to be up at 7 a.m. to kind of jump on a meeting with them. I just think that, even if the meeting is only for like 15 or 20 minutes, that's something that definitely helped. In addition to that, Jazz introduced me to the Miro tool, which actually proved to be very useful when it came to, coming up with the VOC, the fishbone diagram, all of that, since it's kind of like a Google Docs type of deal where users can go in on their own time and just add on to any of the diagrams. And then, later on, I would go in there and edit it and just make it look more presentable. I think those were the two biggest factors for me to make sure that everything stayed going on. And then I know maybe I had a little unfair advantage that, the sponsor was also my father. So if I couldn't get with the team for a week, I would at least get with him just to make sure we're all on the same page and let them know what I'm trying to achieve for this portion of the project, just to make sure that the deadlines were being met. But definitely having just taking control of timekeeping and making sure everyone can meet their deadlines at the same time. Just having that kind of presence really helped in regard to my presentation or my project overall.
Great, thank you.
Yeah, absolutely, Anthony. Best of luck to you on your project as well. I look forward to seeing the results on yours as well, sir.
I appreciate that. I'm probably going to need it.
You got it, man.
He's gonna do fine. Don't worry, Hamed. He's worried, but he doesn't have anything to be worried about. Anyone else on the call have any questions or comments for Hamed? Okay, going once, going twice.
Yes, I have a comment for you.
Yes. Yes.
Hamed said that you introduced him to a wonderful tool called Miro.
Yes.
And how come you kept that tool away from me all these years?
Well, we're going to talk. We're going to talk, Gloria. We're going to have a talk. That's one of the things I was trying to get in touch with you, and I couldn't get in touch with you. No, I'm
for a tool, yeah.
No, but yes, it is a tool that it's been very useful. And to be honest, it's something that as I was developing this business, Gloria, I had to look for something because it was like when COVID hit, and so it was like, okay, how do we do this? And it was something I found at that point in time, but it has been very useful in this environment, and I will absolutely share it with you. No questions.
I'm going to hold you to it.
I'm going to set up a meeting tomorrow.
Okay.
Any other comments or questions? If not, we appreciate everyone joining. We will make this presentation available online. There is a Process Village channel on YouTube that we will download it, as well as we'll download it. We'll put the link on the LinkedIn page for others to be able to see. But I want to thank first of all Hamed for the project and for the availability. I want to thank the panel for being here tonight, and also for you guys who just jumped on. I appreciate it, and hopefully this was something that could benefit you moving forward. So we will have another success session coming soon, and we would love to have you all participate. And I may be reaching out to some of you guys just to kind of be panelists as well. So I thank you, and you guys have a good night, and we'll talk soon.
Thank you. Thank you, everyone. It was a pleasure.
Thank you. Nice job. Thank you.
Hi, everyone.
Good job.
Thank you.
Thanks, Jazz.
Thank you, Mark.